I wanted to introduce Gita Sen, who many of you will know about. She's a professor of public policy at the Indian Institute of Management in Bangalore and an adjunct professor of global health and population at Harvard School of Public Health. She received her MA from the Delhi School of Economics and her PhD from Stanford. She was a member of the high-level expert group on universal health coverage set up by the Planning Commission in India, and is a member of the Mission Steering Committee group, a steering group for the National Rural Health Mission of the Governing Board of the National Health Systems Resource Center. Dr. Sen is on the Scientific and Technical Advisory Group of WHO's Department of Reproductive Health and Research and co-chair of PAHO's Technical Advisory Group on Gender Equality and Health. And she's widely known for her work on sexual and reproductive health rights and is a member of the high-level task force for the ICPD. She co-chaired the Knowledge Network on Women and Gender Equity of the Commission on Social Determinants of Health. She's received many honors, and I won't mention them all, but I did want to mention starting with the most recent, several of her books. One is called Gender Equality, Equity and Health, The Shifting Frontiers of Evidence and Action, and that's only out a couple years. Engendering International Health, the Challenge of Equity, and that is about a decade old. And then another book from just over a decade is Women's Empowerment and Demographic Processes, Moving Beyond Cairo. I'm going to invite Gita Sen up in a moment, but let me as well introduce Bill Hsiao, who is known to many of you for his work on health policy in many developing countries, including Vermont. Professor Hsiao is the KT Lee Professor of Economics in the Department of Health Policy and Management. And he's also, I've had the pleasure of working with him when he headed the health systems work in the Global Health and Population Department for several years, and brought his vast experience and insight into those topics, and gave us a focus in that program on political economy, which I think makes the program have a coherence that is very important indeed in thinking about many of the ethical issues and their connection to political issues that we face in thinking about universal coverage. So he has worked in many developing countries, and his research focuses on the development of sustainable financing mechanisms to provide health care for the poor. So the contributions he makes to this discussion are following fairly directly on Dean Frank's comments about the importance of costing out and using as a guide to what the economic implications of health reform are. I think Professor Hsiao will have much to say about that. So without further ado, let me introduce both. If Gita Sen would come up, there you are, first, and we'll proceed directly from her talk into Bill Hsiao's.
Thanks very much, Norm. Morning, everyone. And let me say what a great pleasure it is to be here. Whenever I'm here, I always feel a little bit guilty because I clearly don't do enough for my adjunct appointment here at the school. But in any case, I'm here right now. And that's a confession to the dean. Let me also say how grateful I am for the opportunity to re-examine the premises of what we've been trying to do in India in the last couple of years. The high-level expert group on universal health coverage was set up by the Planning Commission of India in late 2010. And we were initially told we had 3 months to produce a report, and we, of course, laughed and said, don't be silly. We managed to stretch it to just about a year, and we were very aware in the process of doing so that there were a great number of things that we simply couldn't address in the process of doing that. India is probably one of the latest and certainly one of the biggest in the sort of global move towards attempting UHC. But it's not, and I'll put a yet within parentheses, because life's hope springs eternal, it's not yet a success story. There is no happily ever after in the story I'm going to tell you. I just hope that it's not unhappily ever after stuck as the end of the story of India. But in the process of thinking about what we've been trying to do and the kinds of challenges that we've faced, I took the opportunity to go back over and think about a number of the premises and tools that we've tried to use and how much they've actually helped us or not helped us in the process of this attempt to move forward in India. And I think I basically am trying to make 2 related points. The first being that the usual ethical lens that we use in thinking about universal health coverage can obviously serve as a guide to questions, but at least in our context, has probably been too blunt an instrument. It's not been fine enough or sharp enough for us to get at some of the questions that have really been the most pressing ones that we've been struggling to address. And obviously I'm going to say why I think that. It's not provided us enough help so far for many of the actual choices and decisions that have to be made. And related to this, much as I think that the 3-dimensional box is really cute, and I've spent a lot of time, I'm terrible at geometry, trying to draw that 3-dimensional box from memory without looking at a picture. It does, I'm not convinced that it is leading us far enough towards some of the most pressing ethical questions, especially in the context in relation to the 2 dimensions of people and services. I think on the third one of cost, it's taken us quite a ways, and it's been a major win globally for the UHC movement that we have such a clear recognition and a pretty widespread recognition that direct out-of-pocket payment as a mechanism of funding is simply not a good thing. And I think that we have really made a breakthrough in that area. But I'm not sure that we've made enough of corresponding breakthroughs in the other two areas, and let me say why that's the case. I'm going to make the argument that there are issues that are submerged within those broad agreements about ethical choices, which actually govern the path that we take, and which have quite significant ethical consequences that often remain bubbling beneath the surface, but in fact determine what we can do or cannot do. When the Planning Commission set up the high-level expert group, the HLEG, as it is known in India, one of the first questions that we asked the redoubtable deputy chairman of the Planning Commission, Monte Ahluwalia, looking around the room, was where was the private sector? And he said, you know, I've purposely kept them out. I've kept them out because we hear from them all the time. They're always coming in to chew my ear about what it is that they need, want, should have, and so on and so forth. And I wanted to have the rest of you, to have a space to be able to really say what you think without having constantly to have to engage with and figure out where the private sector was in this. And of course, for a number of the wily old foxes in the room, many of whom were from civil society and so on, the question was the proverbial, well, is it better to have them, you know, in the tent pointing outwards, or have them outside the tent pointing inwards, and whether in fact not having them as part of the process would then allow a different kind of process to happen after the HLEG submitted its report, which would mean that one could then say we're going to engage with them and we're going to engage with somebody else, thereby diluting and possibly watering down what the HLEG might come up with in its report. Anyway, be that as it may, that's just one element in that, as you'll see when I carry on, was quite important. The HLEG certainly agreed with the broad and I think generally agreed universal health coverage goal of maintaining and improving people's health, with the intermediate goals of improving health service access and use without increasing financial hardship, and in fact trying to reduce financial hardship, which in India is quite significant at this point. We also added something which was really not in our parameters, in the parameters that we were given, but which we thought was absolutely crucial in terms of allowing us to move from very hard trade-offs towards actually win-win situations. And that was, of course, the importance of the social determinants of health, which we felt, in fact, provided for win-win possibilities that would allow one to go beyond and sort of leapfrog over some of the trade-offs emerging, but which, interestingly, again, in the universal health coverage discussion quite often, and within that cube, quite often just is somewhere in the penumbra, in the wings, but that isn't sufficiently addressed. And we felt that was really important that we deal with that. I don't think we did a good enough job, partly because we were adding it on and nobody else was terribly interested in it. But the prevention of unhealthy living and the promotion of healthy living, along with the environmental and other changes that were needed to do that, was certainly something that we felt was a win-win, that in the move towards universal health coverage needs to be addressed far more centrally than it has been. So let me, for those of you who are not absolutely sort of familiar with the Indian health situation, just do a very quick thing along the three dimensions of cost, people, and services, which are the three dimensions of our cube. Many people know that low public spending in health, just a little above 1% of GDP, is a hallmark and has been a hallmark of India's spending for a long time. And the 2.5% of Mexico looks marvelous from that perspective. Growing evidence of households falling below the poverty line quite regularly, and of catastrophic and in general non-catastrophic even health expenses as being a serious contributor to impoverishment. The so-called 70-70 syndrome that we suffer from, which is that about 70% of health expenditure is out of pocket, and about 70% of that is on drugs and diagnostics, which, given India's reputation as the world's generics factory, is quite ironic. We're clearly not providing cheap medication to our own people. Secondly, in terms of people, one other thing in the area of financing, the huge federal problem. And I'm not quite sure how in Mexico you address this problem, but in India, health is a state subject, which means that health infrastructure, by and large, is run by the states. And what it is that the central ministry can do by way of moral persuasion or by using the power of the purse is somewhat limited, although, in fact, the ministry at the center has become increasingly more aggressive in trying to use the power of the purse to say, to force the states to move in directions that it thinks are important. However, what do you do with a state that says, we don't care? We won't spend it. You can do what you like. We don't have the political muscle to help us to do this. You can keep the money. We don't want it. And that, I think, becomes obviously not said so bluntly, but in the practice is obviously a very serious question. The state's not spending enough on health, and some of the most critical states not spending enough on health. The second issue is in terms of people, huge inequities, and I want to focus on particularly two big rural-urban differences in a population that is still close to 70% rural in the country. The proportions and the differences, inequities in terms of services, in terms of hospital beds, in terms of health personnel and so on are just, they're laughable. They're so enormous. They're huge. So, and the second one is big interstate differences. So that if you are born in a state like Jharkhand or Chhattisgarh, you probably have somewhere like almost a 20-year difference in life expectancy as compared to if you happen to be born in Kerala or Tamil Nadu or some of the other states. That is, magnificent inequity just within the country itself, and absolutely, has been there and doesn't seem to get very much better. It shows up in other things, maternal mortality rates that are hugely different, infant and child mortality rates that are hugely different across the states, depending upon where you are. The third area of services. Interestingly, if you actually look at India's health policy trajectory, we've actually been producing universal health coverage for a long time. We've had a three-tier system that was supposed to be accessible to everybody and open to everybody at free for practically since the period of independence. And yet, as most people know, this is UHC on paper and has been UHC on paper for many decades. There is very poor availability of services. There's a pervasive shortages across the system of staff, of facilities, of infrastructure, and of such things as supplies of drugs, of testing kits, and so on and so forth. And that would be hardly surprising given that this three-tier system in the public is a public system, and if you're spending 1% of GDP or so, it's hardly surprising that you have the kind of shortages that you have. But in addition to these, if you listen to the debates on universal health coverage in India, there are at least three other things that come up constantly. The first one, and it predates the recent debates on universal health coverage, is the challenge of quality. That even where services are provided by the public sector, there's a massive challenge and a massive shortfall, deficit of quality in the provision of those services, both in the managerial sense and also in the sense of the prevention of access, that in fact people stay away from the services because of the poor quality that they provide. So this is one that has been, and what's the ethics of that in terms of the choices choices involved in moving towards the improvement of quality, which is obviously not costless, is, I think, and has been a fundamental issue in India. A second one is the role of the private sector itself. If you read the World Bank's recent review of universal health coverage experiences in low and middle income countries that just came out a couple of months ago, it's what is very striking, and the report makes a point of saying this, is that the method of implementation is really very wide-ranging. It's not specified. One can have very many different roads leading to Rome or paths leading to God, depending on whichever metaphor you prefer. But how one gets to UHC is largely remains unspecified as long as the broad goals of UHC are met. What this has meant, of course, is that in the UHC literature, there's relatively little on such things as regulation and relatively little on how one ensures a regulatory architecture in the process of moving towards universal health coverage. And I'll say in a minute why, in the context of the Indian debates on the private sector, this has been a crucial issue. And the third one is, again, in the Indian context, a growing recognition of the need for external interlocutors. That unless one has civil society and others who will not only mobilize the politics that is needed, who will not only address the demand side barriers, such as those of caste or gender, that in fact impede the access of critical groups to universal health care, but who will also monitor and watchdog what the government is doing and what the private sector is doing, that if you don't have these interlocutors in place, you will in fact not be able to get to universal health care or health coverage. So what's the path to universal health care that has been that in India? What are the challenges on this path that we've had to deal with? Over the years, the policy responses to these questions have been the following. There's been very little, as I said, on spending until the recent emergence a few years ago of the so-called the health insurance schemes, the so-called, it's an Indian acronym, that says RSBY, which is a government-funded broad health insurance scheme available to everybody, and then a range of what I call the turbo RSBYs, which promise a great deal of money and coverage and so on, and which are put in place by state governments in a number of places. These schemes, which have a short relative history, are deeply, deeply popular with people. They're popular because they address people's secondary and tertiary healthcare needs, but of course they are quite expensive, very fragmented, and increasingly are seen as leading to all kinds of abuses. Abuses because they in fact promote excessive spending, all kinds of, large numbers of hysterectomies, all sorts of things like that, which are in fact emerging in the system. The Planning Commission's 12th Plan final document estimated that India would have to, even if it were to go with what was a scaled-down version as compared to what we had put forward, would have to be spending something like about an increase of 34-35% each year in the 12th five-year plan on what it was spending, if it was to get to just about 2% by the end of the plan. And yet this year's budget has only given us 25% increase, and that's barely. Everybody says we're not going anywhere with this. It's very clear the government says there's no money because India's growth miracle has stalled in relative terms. The rate of growth has fallen. There's no money to spend, and so it's not clear where we're going to be able to go. And in this context, clearly, how is it that one can push forward? Second, the policy response to shortages has been a significant opening and a large number of uncosted subsidies to the private sector. One of the first things that was opened was medical education in the late 1990s. Huge shortages of people and personnel across the board, and the public sector medical schools clearly were not able to do it, and so open it up to the private sector. Except we increasingly know now that that set up a lot of perverse incentives as well in the system, because there's large capitation fees to get into these private medical colleges, and once they do that, nobody who's gone through that is willing to serve in the rural areas or in the poor areas anyway. So what have we got? We've got lots of underemployed medical doctors and others hanging around in the urban areas. So opening up to the private sector really doesn't seem to have done a great deal in terms of easing up on the availability of people. Secondly, land and tax breaks to the private corporate hospitals, the uncosted part. There's no costing of what this means, except we all know that they're sitting in some of the prime land and they don't pay taxes, by and large. In return, they're supposed to set aside a proportion for poor people, proportion of beds and services, and they don't. There are famous cases of Apollo hospitals which are before the courts, which say, so what is it that we've gotten from you for this? So we have more services and people, but high cost, the poor increasingly cut out from services, very, very strong lobbies against regulation of any kind, and not necessarily higher quality. We're very powerful lobbies against regulation of any kind, so that at this point, the regulatory architecture for health in India is a joke. All that we have is a very recent bill that has just about gone through on food standards, a Clinical Establishments Act, which is just largely about registration, which is barely limping through the system, and then something on sex selection that is in place. The final one is the policy response in terms of addressing key groups of people. And because key groups of people were being cut out of the system, we've had the emergence of silos. So the first and biggest one of those was, of course, on HIV/AIDS. So we have a national AIDS control program which is very large, which is focused, and which has contained infection, HIV infection in the country, but at quite high cost. The cost is quite high, and one has to ask, so what does the creation of the silos mean in terms of the ethics of availability? Similarly, with the NRHM, and I'll speak about that if questions are raised, the National Rural Health Mission, whose central focus was on maternal health, but very high cost as well. And the question is, so are these silos, in fact, getting us to the strengthening of the health system, in fact? So what has happened to the HLEG report, which of course argued for putting in place a regulatory architecture, putting in place much stronger attention to the public sector? We're stuck. We're stuck because we, in fact, have very strong lobbies operating against us. And with elections coming up next year, we are stuck because we have strong lobbies operating for things like the turbo insurance, which won't let that stop, but which, in fact, is eating up a huge proportion of the funds that are available. So I think my last and final point is simply that the critical choices really go beyond, for us, the broad goals such as reducing impoverishment, improving health, which are in some sense like motherhood and apple pie. Everybody can agree to them and do agree to them in India. But the ethics of the path is also about how one addresses those three dimensions, the unintended ethical consequences. Not only because the broadness allows cherry picking by governments of what they will do and will not do and so on, but also because the paths chosen matter because they close off other paths. They make the other paths very difficult to follow. And therefore the choice of the path, not just the choice between goals at the beginning, crucially matters. Thank you very much.
Thank you. Good morning. My boss is here, although he won't admit it. And you also wonder why you will invite the economist to an ethics conference. And I also wonder that too. What I like to do is just give you a couple basic message about how the economists will look at the ethical aspects of a health system and a health universal coverage. I will not go through the goals, although the title you assign me is the goals of universal coverage. I assume the audience already know. And then everyone already talked about the three-dimensional aspects of the universal health coverage. And I'm going to show you later on, I think those cubes are inadequate. Actually, they camouflage some really important ethical issues you have to face. So as economists, I want to bring you to reality. And that's what I call rubber meets the road. Namely, you need money. And to bring about money, we know in healthcare financing, there are 4 major basic functions in healthcare financing. First is you have to design methods. You can mobilize the resources. Here people just say, I want money for healthcare. But Minister of Finance, as well as the Prime Minister, always have to say, where am I going to get the money? From taxes, from social insurance, or from community financing, from private insurance, which Gita talks about in India, how they administer their hospital insurance. But there's one unique aspect of health which no other sector had to deal with, namely, as Ken Arrow wrote in 1963, what's unique about healthcare is uncertainty. The uncertainty of that you or I will become seriously ill. In this room of 100 people, maybe 1 or 2 of us will become seriously ill in the coming 12 months. But 98% of us will be still healthy. The same thing goes with health diagnosis and treatment. I will argue medicine is not a pure science because individuals are different in our molecular and biological makeup. So in diagnosis and treatment and how individuals respond to drugs are highly variable. So consequently, in health, we have to pool the risks. That's one key element in financing healthcare. Then when you actually mobilize the money, you pool the risk, now you have the money power. How are you going to allocate the money? That actually deals most directly with this ethical issue. Who gets the benefit? But I like to point out, even mobilize the money, that determines who pays for it. Is the rich people pay for it, or the middle income, or the poor people pay for it? So this part here, this part here, this part here, all deals with equity and fairness. So then I like to at least highlight some of the issues that I find as an economist I have to deal with. First, in allocating resources as well as who you're going to get the money from, you rely on the ethical beliefs or the values of that nation. I have been engaged by more than a dozen countries to actively, closely involved with redesign their health system. The fundamental question we go into is always, and I have a case, is I as an outsider should not determine your ethical principles for your nation. You have to decide. Now here, my respected dean talked about social rights, human rights. But let me tell you what I discovered in the real world. That's not universally accepted. Let me give you a concrete example. Singapore openly declares equity is not my primary goal. In Singapore, self-reliance, rely on yourself, is the primary social value for Singapore. equity comes second. As a result, Singapore only assures everyone with the so-called basic health care, but not equal health care, even for a very wealthy nation. I would like to share another example. Back in 1990, China did not know how to deal with health care. The top people ask a fundamental question: what is the nature of health? The nature of health in human lives, and then what's the nature of health care? The Politburo member said, if you can answer that question for us, then we know how to allocate our resources. And also, what's the role of the government and the role of the private market. We actually then organized a group of philosophers from the West, as well as a group of philosophers from within China. They are Marxist philosophers, along with economists, and debated. You can look up the historical record. This is called Franklin Hill Conference in 1991. Once we say the nature of health is essential for human well-being, not for economic development, but it's actually for the human's well-being. We argued, even if you are a billionaire, you do not have good health, you cannot enjoy your wealth. Economic growth from good health is only secondary. We put health along same as economic well-being. Then China says, then the government has the primary responsibility to ensure everyone has basic health care. But every nation struggles with what's the ethical foundation for health care. And that's my experience, and I would assert, and I hope you would debate, whether to what extent there's a universal value, which most of us in this room will argue there's one, versus when you talk to the prime ministers and minister of finance, whether there is a universal value for that. Or do we have a long way to go yet to reach that? So ethics is a fundamental aspect in financing. Then that determines who gets the benefits and for what, who pays, and so forth. So then I'd like to remind everyone here a fact you already know well. What's declared in this noble goal of universal health coverage is not insurance coverage. Universal coverage means effective coverage. Many nations I deal with, including China, was to actually get insurance coverage to everyone, but services may not be there. And this, for economists, is really important. You have to deal with the supply side. When you declare universal coverage is your goal, you have to make sure you have the supplies, including essential drugs, available to people. But today, what's prevalent in the world is how many people do I get covered? Look at countries like Ghana. which has declared universal health coverage a decade ago, to what extent they are able to make effective services available to people. So this is the other aspect, which is, if we want to deal with equity and fairness, we need to worry about effective coverage rather than just coverage, which often means insurance coverage. Now let me just deal with this cube. To me, that cube is overly simplified. This is the depth, that is share of the cost paid by people, and this is the breadth, that is the population. I divide the population into 3 income groups for simplicity's sake. So top 20% of the people, next 30%, next bottom 50% of the people. This part here is scope, what services are covered. I actually drew this diagram by studying roughly the kind of coverage over 40 nations. You will look at the top 20% of people. Many of them have very good insurance coverage. By the way, they're mostly civil servants, plus employees of multinationals. But they're still uneven. Some have more, some have less. The other 30%, the same thing, but they usually have less. For the bottom 50% income, you see some of them have nothing. They are not even vaccinated. When they are pregnant, they have no prenatal care. I don't need to enumerate those problems for this audience. So the cube does not show this unevenness within a society. So when you're trying to allocate resources, if you have limited resources, an economist like me believes we do have limited resources. Then, if you have a poor, if you have a poor policy, you may want to actually cover the services that's really essential, that's most cost effective, rather than trying to reduce how much people want to pay, have to pay. Then for the other, then you may want to equalize them more. And then when you have resources, you can keep pushing it up to equalize. For your information, that's exactly what China is doing. China says, I'm going to cover everyone with shallow insurance, but I'm going to first emphasize prevention. Then I show you what some other countries are doing. You might wonder, what country are these? Nigeria, United States, Tanzania. When they expanded the coverage through private insurance. That means who can have the ability to pay, as well as for civil servants. Look at the Tanzania and Nigeria. They declare universal health coverage, but who got actually covered? Civil servants, not the common people. This, to me, is what this conference is all about. Help nations to set their priorities. And it's a difficult job. So I want to thank you for your attention. Bye.